Hello, everyone. So I want to begin off by thanking everyone for coming out to this. I think it'll be a very interesting talk. It's with great pleasure that I get to introduce Rupa Narra. As many of you guys know, she was a resident here at Children's Hospital and then got bit by the international medicine bug and spent some time in the emergency department while she was traveling around figuring out how she was going to make international medicine part of her life. Since that time, she's been to some amazing places. She's worked with Doctors Without Borders, where she's been in the Sudan and in India. And now she is working at the CDC. So I was working one of my shifts in the emergency department, and everybody was getting all excited about what's going to happen with the Ebola cases. And I was working with one of her good friends, and people who have been following her on Facebook said, "Oh, did you hear what Rupa's doing? She's doing this, she's doing that." And it just came to us at like 2 o'clock in the morning, we should get her here for a talk. So a massive amount of emails going out, and it ended up happening. So thankfully, we were able to open up a date, and we'll have her discussion followed by a panel discussion about Ebola and some international health. So with great pleasure, here's Rupa Narra.
Can you guys all hear me okay? Okay. First of all, thank you, Pat, for that warm welcome. And also, I want to thank the section of emergency medicine, the section for infectious disease and epidemiology, and also the Center for Global Health, because they were the ones that kind of orchestrated everything with getting me here. So it's a real honor to be back. Okay, let's get started. The world is facing the largest Ebola outbreak in history. Ebola is a rare and deadly disease that dates back to 1976, when the virus was first discovered along the Ebola River in Yambuku, Zaire, which you can see right here. This map shows previous Ebola outbreaks that have occurred, most being in the central part of Africa, usually around tropical rainforests. The different colored circles in this in this picture, represent different strains of Ebola virus, and the size of the circles correlate to the number of cases associated with each outbreak. The map is from early on in the outbreak, which is why this circle is so small compared to the cases that we are seeing now. West Africa's previous experience with Ebola was only one case that you can see here of the Thai forest Ebola virus, in which a scientist became ill after performing an autopsy on a wild chimpanzee in the Thai forest in Ivory Coast. He actually survived, though. The term Ebola virus disease has now replaced the previous term Ebola hemorrhagic fever, taking into account that hemorrhage has been seen in less than half of the cases with this epidemic. Ebola virus belongs to a family of zoonotic RNA viruses called filoviridae, named after their thread-like appearance shown in this colorful electron microscopy image. There are 5 identified Ebola viruses, species, 4 of which are known to cause infection in humans. The rest in Ebola virus has actually never caused disease in humans, but has definitely caused disease in non-human primates. Case fatality rates have ranged anywhere from 30 to 90%, depending on the species. Through viral sequencing, the species responsible for the current outbreak was found to be the Zaire Ebola virus, the most pathogenic of the species. How do these outbreaks occur? Ebola is thought to be a classic zoonotic infection with the presence of Ebola virus in a reservoir species usually found in endemic areas. Bats are the presumed reservoir for Ebola, shown on the left side of this slide. The belief is that some stimulus triggers bats to sporadically pass the virus to other wild animals or to humans directly. In addition, preparation and consumption of bushmeat or other wild animals, such as monkeys or bats, may also cause part of the spread to humans as well. Once an outbreak begins, human-to-human transmission is the main source of transmission. From previous outbreaks, we know that direct contact with blood or bodily fluids from an infected person is the major route of transmission. Potentially infectious bodily fluids are listed here, and that they can contain Ebola virus. These include blood, respiratory secretions, urine and feces, vomit, saliva, sweat, breast milk, and also semen and vaginal secretions. Other possible routes of transmission include breastfeeding or sexual transmission. However, this has been very hard to determine with data. As you can imagine, it's difficult to distinguish if the transmission actually occurred through these activities or through close contact itself. Regardless, condoms are recommended at least for 3 months after infection in certain cases, and alternative feeding sources for infants are recommended if mothers are found to be a case. This is an example of a poster used by MSF, actually that we used in Guinea, that kind of shows, at least to a lot of the illiterate populations or people that were in the villages, just how this virus can be spread, just to give you an idea of what we actually show in the field. Some key concepts. Unlike influenza and other viruses, evidence from previous outbreaks indicates that people infected with Ebola are not contagious until the onset of symptoms. Infectiousness and viral load of a patient and bodily fluids increase as the person becomes more ill and actually peaks at death. As mentioned, direct contact with symptomatic patients or his or her bodily fluids are the most common transmission mechanism. Corpses are highly infectious. For this reason, several people are affected during burial rituals, which usually involve hugging, kissing, washing, and rubbing oils onto the body of a deceased loved one. Transmission also occurs by contact with objects or surfaces contaminated by blood or other bodily fluids containing the virus, such as soiled linen or clothing, medical waste, used utensils, or used PPE, or personal protective equipment. If you take away one thing from the slide, remember this. Infected persons are not contagious until the onset of symptoms. This slide lists the signs and symptoms of a patient with Ebola virus disease. Fever, chills, malaise, and muscle pain are usually the first signs and symptoms, followed by headache, vomiting, diarrhea, and abdominal pain. Hiccups and hemorrhage are usually a later sign. Of note, hemorrhage is actually, as mentioned before, seen in less than 50% of the cases, and it is usually a mucocutaneous bleeding or epistaxis that will occur. GI bleeding is much less common, but miscarriage is very common in pregnant women. As you can see from these symptoms, Ebola can mimic several other diseases in this part of Africa: malaria, typhoid, meningitis, many other things. Co-infection is common, but it does not rule out Ebola, obviously. The incubation period from exposure to the beginning of first signs and symptoms is 2 to 21 days, but the average is actually 8 to 10 days. Between different organizations in different countries, there are some minor differences between case definitions in West Africa, but for the most part, the principles are the same. The WHO categorizes cases into 3 groups: suspect, probable, and confirmed. This is a picture of a hospital staff member walking through a chlorine foot bath, which is usually placed at different entry and exit points in an Ebola treatment unit. This is actually a MSF treatment unit, or Doctors Without Borders. Here is a picture of an MSF Ebola treatment unit in West Africa. The most important aspect of an ETU is unidirectional flow for patients and staff that will be moving from lower risk places of Ebola, such as a suspect area, to higher risk areas, which would be a probable case area, to the highest risk area, which would be confirmed case areas and also the morgue. What is a suspected case? Any person, alive or dead, suffering or having suffered from the sudden onset of high fever and having had contact with a suspected, probable, or confirmed Ebola case, or a dead or sick animal, or any person with a sudden onset of high fever and list at least 3 of these symptoms, or any person with inexplicable bleeding, or any sudden or inexplicable death. So as you can see, a lot of people in these parts of West Africa can fall into the suspect case. A probable case is any suspected case that is evaluated by a clinician and deemed to be a more likely probable case of Ebola, or any deceased suspect case without laboratory confirmation having had an epidemiologic link with a confirmed case. And a confirmed case is any suspected or probable case with positive laboratory results by real-time PCR, which is usually done on blood, very rarely sometimes can be done on saliva or oral swabs, and also by serological testing. Now that you know what a case is, I want to clarify what constitutes contact with a patient. Having been exposed to a suspected, probable, or confirmed case of EVD, which can be translated as sleeping in the same household, having direct physical contact with the body, bodily fluids, or contaminated object of a symptomatic case, or physical contact with the body of a dead case. For contact tracing, which I will describe later, the contact must have occurred in the past 21 days to be identified as a contact. Of note, the definition of contact has been misused several times in the media. And the CDC definitions of risk-based levels and also degrees of exposure for domestic purposes vary compared to what you see here. This is really what's being used in the field to define what a contact is, as in West Africa. Now I'd like to tell you a little bit about the beginning of this epidemic, where we believe where some of the first cases began. To orient you to this map, this is Guinea, here's Sierra Leone and Liberia. We believe that the first cases actually occurred down here in the southeastern part of Guinea. This is an updated transmission chain, actually, that was recently emailed to me from some colleagues of mine that are in Guinea currently. Some of the recent articles, I think the New England Journal of Medicine and the New Yorker had some different aspects of the the transmission chain. So you may see a little bit difference with the dates, but this is probably the more updated version because they've gone back and done repeated interviews to try to get it as updated as possible. So it was created by a group of epidemiologists from different organizations, including the World Health Organization, Doctors Without Borders, and also the Ministry of Health, who all performed epidemiologic investigation by reviewing hospital charts, interviewing patients and their families, and also people that lived in these affected villages. To orient you, a healthcare worker is represented here with this H with a hat. The cross represents a death, and this gold box represents a probable case. Meliandu is believed to be the village where the first cases began. The initial origin of where this epidemic began is unknown, but we believe that a first case began in a 2-year-old child who presented with symptoms on December 22nd. She died, but went on to infect her 3-year-old sister who developed symptoms at the end of December and also died. Next, the mother of these children became infected and also displayed signs of hemorrhage, which were carried out in the form of a miscarriage. Before dying, she went on to infect the grandmother of the family, a village midwife, and another woman of that village, all of whom died. The midwife then went on to infect a group of people in this village you can see here called Dondo Pombo, which is not very far from Meliandu. It's also in this region of Gekadu. And also the grandmother was admitted in a hospital in Gekadu and infected healthcare workers there, people in this local town called Dawa, and also a nurse that's local. And just to let you know, so you can see how this chain is, these would all be their own chains, similar to this and ongoing, and ongoing. From Gekadu, healthcare workers there went on to infect others. The nurse that you saw here went on to infect another person in her village and her 6-month-old son, both of whom died. And then cases from Gekadu went on to infect people in Misenta, Kisidigu, and also the capital city of Conakry. Now, just to kind of reorient you with where that would be on the map. So here's Gekadu. You can notice how close that is to the border of this tri-country region. Misenta is over here, and Kisidigu is over here. Conakry is all the way over here, so you can imagine most of the time people will take public transportation and they go by this route to get all the way over there. This graph is an epidemic curve that shows the total number of cases, suspect, probable, and confirmed on the y-axis here, and the week of onset of symptoms by epidemiologic week on the x-axis from December to June. Guinea is shown in orange, Liberia in blue, and Sierra Leone in green. As you can see, there were a couple alerts early on to the Ministry of Health about some of these cases. But since Ebola had never been seen in this region before, people didn't really think of that when these alerts came up. On March 21st, however, the Guinea Ministry of Health reported the outbreak of an illness characterized by fever, severe diarrhea, vomiting, and a case fatality rate of 59% in 49 people. Specimens of 15 of those 20 people came back positive for Ebola by PCR, which the specimens were actually sent to Institut Pasteur in Lyon, France. The WHO, the Ministry of Health, and MSF all became involved here, along with the CDC, to try to kind of help and curb this outbreak. According to the WHO, the first confirmed case in Sierra Leone was a young woman who presented to the government hospital following a miscarriage in Kailoun, Sierra Leone, on May 24th, 2014. Ebola was confirmed on May 25th. And just to show you where Kowloon is, just to kind of give you an idea, that's right here. In tracking the source of her infection, the Ministry of Health uncovered an epidemiologic link that led to the discovery of several other cases in Sierra Leone. There was a widely known and respected traditional healer from the region of Kowloon. As the outbreak in Guinea initially continued to grow, desperate patients sought her care, and it was believed that she traveled to Guinea to provide her services over the border. The healer became infected with EVD and died, and hundreds took part in her burial ceremony. Quick investigations by local healthcare workers can link her death back to as many as 365 deaths from Ebola, according to the WHO. Just to come back. And this photo was taken on June 13th, 2013, in a village in southern Sierra Leone. It shows several relatives performing a traditional kind of burial ritual. And a lot of times, like we mentioned, many of these family members would take part, or relatives, close people in the community, and I described as taking part with, hugging the body, mourning on top of the body. So you can imagine how that could spread, especially when a deceased patient is at the most infectious place. This map is from June 12th. The tan regions, just to orient you, represent suspected cases. The orange regions represent confirmed and probable cases. Striped regions here actually represent no active transmission during that time. The H's represent Ebola treatment units that were in the areas at this time. And just to note, so this was in June, as mentioned, and just as in Conakry, which is the capital of Guinea, you can see here that Freetown, which is the capital of Sierra Leone, was also severely hit. This was likely due to overcrowded living conditions and the fluid population movements that we had described. This is the first Ebola outbreak that has actually occurred in urban settings. Note the heavily affected areas as well on this tri-border region that we had discussed. Ebola does not respect borders, as you will see. I know many of you heard about all these cases, but I think it's interesting to kind of give you a little insight to the background of some of these patients that were over. On July 20th, a traveler flew from Monrovia, Liberia, all the way over to Lagos, Nigeria. Lagos has a population of almost 20 million, which is close to the population of Guinea, Sierra Leone, and Liberia combined. So you can imagine the panic that this one imported case had caused. The case was a 40-year-old Liberian man who was symptomatic while traveling. He was admitted to a private hospital almost immediately and died 5 days later. His test came back positive for Ebola on July 22nd. Through rigorous contact tracing and early identification of cases, 894 contacts were identified and followed. There have been no new cases since September 5th, and on October 20th, Nigeria was deemed free of Ebola. This means that 42 days, or 2 EVD incubation periods of 21 days, have passed since the last day that any person in the country had contact with a confirmed or probable case. Senegal. On August 29th, Senegal reported its first case of Ebola. The case was actually a 21-year-old male who was a known contact to a confirmed EVD case in Guinea. He arrived to Dakar by car on August 20th and sought medical care. He was initially seen at a medical clinic on August 23rd for fever, vomiting, diarrhea, and was treated for malaria and sent home. With ongoing symptoms, he was admitted to a specialized infectious disease facility on August 26th. On August 27th, healthcare authorities from Conakry, Guinea, actually issued an alert informing neighboring countries that this person had escaped the surveillance system. As a result, investigation and very urgent contact tracing took place, which proved to be successful. 74 contacts were followed for 21 days, and no secondary cases were reported, which is pretty amazing. And then since October 17th, Senegal has also been deemed Ebola-free. Okay, and now Mali. On October 23rd, a 2-year-old girl from Guinea was confirmed to have Mali's first case of Ebola. Investigation revealed an extensive travel history of the child and her grandmother. On October 19th, the grandmother actually came down from Mali to attend the funeral of what is believed to have been the mother of this child who died of EVD-like symptoms. And just to orient you to this map, so I took this box is down here. So this is the eastern part of Guinea, and then obviously this shows the relation of Guinea to Mali. So they traveled from Kisidougou, which you can see here, to Kankan, here, to Siguri, to Bamako, and then to Kayes. Per report, the little girl had a bloody nose during this extensive travel that they used public transport. Unfortunately, she died a few days ago. Investigation is ongoing. There are 43 contacts that are currently being followed, possibly more at this point, 10 of those including to be healthcare workers. To bring it back to our three mainly affected countries, I just want to show you guys the difference that 3 months can make. So this is the initial first map that I showed you, and this is from June, and then this is actually only from September. So just to kind of show you the spread that it occurred. This is a list of all the reported Ebola cases and deaths in Africa that have occurred in the population and in healthcare workers. As you can see, there have been 13,698 cases with close to 5,000 deaths reported. This is as of October 29th, just to let you know. The total healthcare workers that I'm listing, the most recent data I could get on that was October 14th, just to update you too. So 417 healthcare workers have been reported to have contracted the disease, with 239 deaths. Of note, the healthcare workers are listed by the country in which they were actually infected with EVD. And as you can imagine, recruiting healthcare workers was already difficult, but now with this on top of it, it's been proven to be even more of a challenge, obviously. Several people have asked, when do we think this epidemic is going to stop? These next two graphs are examples of transmission modeling that were done by very smart people at the CDC. Not myself. To orient you, the y-axis here is cases by the thousands, meaning, yes, this is almost 1.5 million up here. And then on the x-axis is obviously just the dates. So solid blue lines represent the uncorrected case counts reported to surveillance systems, and the dotted blue line represents modeled case counts corrected for underreporting. We estimate that there are actually 2.5 cases for every one case reported, because underreporting, as you've heard, I'm sure, is a huge issue over there, which I will explain later. And so this slide shows predictions without interventions, meaning what we can expect if things will remain as they currently are. Without additional interventions or changes in community behavior, the CDC estimates that by January 20th, 2015, there will be a total of over 500,000 Ebola cases reported in Sierra Leone and Liberia. This would actually mean that there would be 1.4 million people ill in these countries with Ebola. This graph is actually meant to show what we can assume if multiple interventions take place. So intervention is defined as removing 70% of Ebola cases from a community setting and either placing them in an ETU, an Ebola treatment unit, or a non-ETU community center if ETUs are at capacity, but basically getting them out of that infective risk from being at home. This also would include safe burials. This graph shows the transmission ending by 2015 if effective interventions are in place by December. Again, 70% of these cases being removed from their homes. This shows exactly how vital it is to disrupt the Ebola transmission in communities, and it also gives us hope for stopping the epidemic if these interventions are made. In order to document the impact that these interventions would be making, lab confirmation is vital. So, Ebola is detected in the blood after the onset of symptoms, notably fever. Real-time PCR is used, and the virus is usually detected between 3 to 10 days after the onset of symptoms. Venous blood is the standard, but as mentioned before, saliva can also be used. It's much less sensitive, so it's really not preferred, but the cases in which you would use saliva would be if somebody either came in dead already or if someone was in the community and you wanted to prove. So sometimes they will take an oral swab and then try to do PCR from that. This graph depicts in a schematic, not a quantitative way, how the virus looks and the antibody levels change over time in patients who actually recover from Ebola. Day 0 here is actually the day of symptom onset, not the day of infection. First, as you know, viremia increases rapidly and actually reaches very, very high levels. Effective IgM antibody levels appear within the first 7 days of symptom onset. IgG antibody usually begins between 6 to 18 days and peaks between 2 to 5 months. IgG antibody, we believe, we know it lasts at least 3 to 5 years with Ebola. It's thought to have lifelong immunity. I believe that the longest case that they followed was up to 10 years that they proved that IgG was still present. But for lifelong immunity, it's an assumption. We haven't actually had any data to prove. But of note, in the field, we usually do not have serology. There's very few labs that actually have this. So again, it's kind of a hard thing to prove. Now I'd like to discuss what made this particular epidemic so hard to control compared to the past outbreaks that we've seen. To orient you, this is a picture I took from Guinea looking across to Sierra Leone, which is over here. As you can just see, this is the small river that's separating the two. There are several porous borders like this one in Guinea and all of the affected areas in Sierra Leone, Liberia as well. Sierra Leoneans would cross this river weekly to actually attend a market in Gekidou, which would be every Wednesday. Also, several cases had families on either side of the border, so they would transport each other back and forth very often, and you can imagine what that would do as well. And border control is pretty much either non-existent or very difficult to enforce in a situation like this. High population mobility is another problem. There are multiple means of public transport, such as motorcycles, taxis, overcrowded taxis. I've seen taxis with almost 16 people in one, overcrowded buses, boats, and all other types of things. And you can imagine that makes it very difficult to kind of keep track of cases, contacts, and everyone because a lot of people are pretty mobile most of the time. In addition, people use these multiple forms of transportation to actually travel between rural areas and urban areas. And transmission in major populated settings with crowded living conditions already just adds to the problems. The geographic breadth across which these populations travel, as mentioned as well, is another problem that we face. The healthcare systems in these countries were quite limited even before the epidemic. Now with Ebola, you can imagine how the healthcare systems and the public health system have been overburdened. Even in some cases, healthcare workers can actually go unpaid just because of lack of funds that are at the country level. When I was in Guinea, I know our contact tracing team went without pay for over 6 weeks. Luckily, they were out of the goodness of their heart and knowing that they wanted to stop the outbreak, they kept working. But also, as you can imagine, there's insufficient supplies, which you've probably heard of too. Insufficient supplies, treatment centers, beds, personal protective equipment, and so on. But even if you have all of those things, logistical difficulties can be quite a problem as well. This is actually a picture I took when I was driving from Conakry to Gekidou in Guinea. And yes, the water is almost up to the window here that we had to get through. We were in an MSF vehicle like this, and it was one of the few vehicles that could actually get through. But this is a classic picture of a lot of the roads that you will come across in these remote areas. And there are small planes that might travel, but you can imagine these runways are like a long dirt road. So several weather things, it doesn't take much to be able to stop a plane. And so getting the actual supplies to these places was a big challenge. Resistance and rumors. So this is actually a picture that my friend took. She was on a contact tracing team in Gekidou, and they came across this, which is a group of angry villagers with sticks and basically trying to put down a physical road blockade to prevent the team from getting through. So you can imagine any outreach activities, including an ambulance trying to go and get a case, contact tracing, a burial team, a disinfection team, a health promotions team, anyone trying to spread the correct word. This could be obviously very impeding. The other thing is a lot of the rumors that occurred when we were there. So when I was there, I heard several people in the community saying things of the sort, MSF brought this disease here, or white people brought this disease here. I will never go to an ETU. My blood and my organs will be taken from me if I go. I'll die in my home instead. And really trying to get the buy-in from these communities was very challenging. The other thing is this area and these 3 countries where that border region I was showing you have been desecrated by war for several years. So there's already a lot of distrust that's built into these regions. So lots of challenges to overcome. In addition, I don't know if you guys read about, there was 8 people from Guinea that were killed, actually, that were on a health promotions team. They were in Zirikori. Some of those people were actually from our team that were just trying to go and dispel these rumors. But again, you can imagine how this resistance can affect the outbreak and also the lack of resources and things. So epidemic challenges, burial customs as well, which I've discussed. So funerals with the ritual washing of the corpse we discussed. Inconsistent alerting of healthcare officials of the deaths in the communities. A lot of times when I was in Gekidou, there was a small village near us called Sandia, and we got a rumor from a man that was on our team, on the MSF team, who had a cousin that was in this area of Sandia, And the cousin was telling him, yes, we just helped bury almost 15 people this week. And no one had known about it. There was no alert. We weren't aware, but no one would let any of our teams go in to do any investigation, to do any burial. And so a lot of times if these villages want to keep everything quiet, they're going to, and we wouldn't have heard about it if a family member wasn't there. But also the lack of acceptance of safe burial practices. And I was telling a few of you guys this the other day, not just in West Africa, but even here, you can imagine the safe burial practices include what you see here, which this is a picture from Liberia, people in full PPE, and there's basically all these graves just kind of lined up next to each other. But to imagine someone walking in, your loved one's there who just passed away, you're not allowed to touch them, someone in a spacesuit walks in, sprays them with chlorine, takes them away, and then buries them, and you never had a chance to touch them, do any of your normal rituals. So you can imagine how difficult that is. And in the field, we do have anthropologists and psychiatrists and psychologists and all kinds of people with the village elders that try to communicate to the populations, but still these embedded, burial practices and rituals, and just being human is a big challenge, obviously, with that. So overall goals in an outbreak response, obviously the number one thing which we had discussed is stopping human-to-human transmission. This is done by case identification, contact tracing, infection control, and safe burials, as mentioned. And patient care is as important. Triage can be a little bit tricky as we went through that long list of a suspect case. So experienced or trained staff is very important, but also very difficult to come by, as you can imagine. And the strict use of personal protective equipment, both putting it on and taking it off, as I'm sure a lot of you have learned, is another key part. This is actually a picture of one of my good friends. Her name's Emily Veltis. She's been with MSF for the last year. And she was on a health promotion team in Kailoun, Sierra Leone. And this is her with the survivor, actually, which is a nice picture. So what is the CDC doing in West Africa? So there's hundreds of staff. There's about 160 CDC staff currently that's in West Africa dealing with both the affected and also the less affected countries. And you can see from the list here of a lot of the different things that they're doing. This is actually a picture of another fellow of mine. She's an EIS officer. Her name's Jenny Harris. So we went to the lab, and this is a bunch of lab samples soaking in chlorine. But you imagine we'd get maybe 30 cases a day, and some of the time these cases would come in unconscious or dead without a caregiver. And so we had no clue when's their date of onset of symptoms, what village are they from, what's their name, how old are they, nothing except maybe a male or female. And so we'd go to the lab area several times a day to try to figure out if we could match stories that we heard with a sample. But that's what that picture is from. Other things that the CDC is doing, as you can see here too, is working with country embassies, ministries of health, and other partners to implement social mobilization and trying to get the message out there of, really what is Ebola, how is it transmitted, and also to try to dispel rumors. And also partnering with some telecommunication companies. So some of the very remote areas, as you guys probably know, even though there's no electricity, there's no nothing, people still might have a cell phone. And so sending, text messages in local languages to explain, again, what is Ebola, where's your local health post, where's a local Ebola treatment unit, how is it transmitted, what are the signs and symptoms? That's another thing that we've been trying to do. Helping set up these surveillance systems in the less affected countries. That picture of Jenny that I just showed you, she's actually in Mali. She was there for the last 3 weeks, and so she was there when that first case actually came across, but luckily they had started to try to already get a surveillance system set up in that country. Guinea-Bissau, as well as Cameroon, and some of the other local areas are where a lot of my friends have been dispersed to now as well. Additionally, working with airports and airlines to assist with exit screening and travel restrictions, as you can imagine. So another thing that we've been doing, and this is actually what I got involved with when I got back from Guinea, is a CDC training course, and it's mainly meant for healthcare workers that are planning to go to West Africa, not here, and treat Ebola within an ETU, or an Ebola treatment unit. So this course is in Anniston, Alabama, which is close to Atlanta Airport, and the reason we chose it, it's actually a FEMA site, and so it was pretty easy to use, and they had a lot of supplies we needed. But what the goal of the course is basically it teaches different healthcare professionals a lot of similar things of what I showed you guys here. What is Ebola? How is it transmitted? But the main purpose is also how to keep yourself safe inside an ETU. So we go through rigorous drills of putting on and taking off PPE, again, as a lot of you guys I'm sure have gone through. And then there's lots of lectures on infection control, personal protection, and then the epidemiology and things. But if anyone's interested, I'm happy to talk to you guys about this after. So now to just move on about issues for children. So As mentioned, data collection has been pretty challenging for this epidemic, as mentioned by some of the examples that I've said. And a lot of the WHO situation reports that come out every couple of days do not include demographics. So this is actually from a New England Journal of Medicine article that I found in September. And it includes data from Sierra Leone, Guinea, Nigeria, and Liberia. And of note, this is a small cohort of patients that they took. There's only about, I think it shows 1,400 patients or so. And at this time, there was about 5,000 cases. So again, this is kind of a small cohort. But from this table, we can see that 14% of all patients infected with EVD in this cohort fall actually under the age of 15 years. Of those under 15 years, 145 out of 190, or 75% of them actually died. But that's similar to the overall case fatality rate, in case you were curious. Children have actually been relatively spared in past outbreaks, similar to this one from the data we have. The thought is that children are not usually exposed to the sick people, and it's more of the time they're not the caregivers that are doing the cleaning up of a lot of the vomit and diarrhea, which is how also a lot of people can get infected. And during the Kikwa outbreak, which was actually in 1995, over 50% of the population was under the age of 18, but 9% of the 315 cases were actually in that category of under 18 years of age. So you can see how they were pretty spared. And for household context, 30% of those over the age of 18 actually became infected, in comparison to 4% under the age of 18. So those over the age of 18 had a 6.8 times risk of actually contracting Ebola in that situation. Issues for infants and pregnant women. So infants of mothers who are suspected or confirmed cases of EVD, we recommend that they should not have close contact with their mother if they're actually in an ETU and if the mother is conducive to that. Also, we try to require and provide safe alternatives to breastfeeding if available. I know MSF and a lot of their Ebola treatment units, they always had formula that was readily available, and also that they would send home with the patient and the mother if the mother did survive. With pregnant women, vaginal bleeding is a common symptom, and it's often profuse. Mortality is usually extremely high in these women as a result of that, and there's, like we mentioned, high rates of spontaneous abortion. Pregnancy loss has been recorded to be close to 100% in these cases. Other issues that are affecting children include healthcare system collapse. As mentioned again, a lot of these healthcare systems were already very fragile even before Ebola came, and staffing these places with a regular healthcare worker or staff was very difficult. But now families are also afraid to even bring their children to clinics and hospital because they're afraid to contract Ebola. So normal treatable conditions like malaria and pneumonia are going without being treated. Routine immunization programs are actually also being suspended in several parts here. So the concern is that the next outbreak in these regions is going to be vaccine-preventable diseases. Schools. So schools have been closed in several areas, as you can see as well, in fear of spreading the disease. So UNICEF actually reported that 16% of the children in Liberia were affected by this, and over 1 million in Sierra Leone. They've been trying to do some types of radio messaging in order to reach children, just to spread messages and keep education up. But again, as you can imagine, that's been quite challenging because a lot of people in the remote areas do not have a radio. So this is a quote from a doctor I worked with. Actually, she came to this Alabama course. She's a pretty renowned pediatrician, and she's Liberian by birth, but she's actually been working in the United States and going back to Liberia part of the time. But this is a powerful quote, and she said, "This Ebola has a much larger problem than we need to look at. And that problem is the children who are losing their parents, their grandparents, their aunties and their uncle, and they're left on their own. What can we put in place to help these children?" So orphans, this was probably the most heartbreaking part of being in Guinea, and I think in any of the affected countries that my friends can attest to. There was already a lot of stigma for any patient or case of Ebola. So this is actually a case of an 11-year-old girl who is a survivor, but she lost both of her parents to Ebola. And she's like thousands of other children. And the problem is in other natural disasters or other infectious disease problems we've seen in the past, these orphans would still be taken up by the family or their communities. But it's the first time that a lot of these children now are being completely stigmatized and just left because nobody wants to go near them, even the survivor children. So that's, again, one of the more heartbreaking things I think of this epidemic that I've never seen in any other situation in some of the developing countries I've worked in. Okay, so now I'll just go, okay, now I'm a little more relaxed. So I'm going to move from behind this thing and just tell you guys a little bit about my experiences in West Africa. So like I mentioned, I was actually in Gekadu for about a month, and this is the picture from the back window of my office. So we were connected pretty much right up against one of the Ebola treatment units that MSF had opened. And you can see it's French, and that was challenging in itself. But so this was an Ebola treatment unit. When I first arrived, I think there were about 80 beds, and they had maybe 40 patients when I had first arrived. And then I remember within a week, they had a tripling of their census. And so at one point, I remember 45 people arrived at the same time with the same amount of staff that was there. So you can imagine, they didn't have enough mattresses, they didn't have enough anything, and they were just trying to rapidly put up tents and mats or anything on the floor just to be able to put people in. I'm sure some of you guys have read in Liberia, they actually had to turn patients away because there's not even enough space. But that's why you see a lot of this construction and things going on, because they just kept trying to rapidly expand the areas. So this is a picture of two of my colleagues. This was the office in Conakry, actually. So data management was initially what I went to do, which was basically, entering cases, which I thought, this is going to be pretty simple. I'm going to go to the MSF groups and get their data and enter their case report forms, and it'll be nice, very easy. And then, as I mentioned to you guys, how difficult it is to get correct data, even an age, even a date. There's never a clear date of onset of symptoms, a last name. There's probably 10 John Camaras that live within a 3-mile radius. So lots of challenges that you can see and that we faced with data collection and management. This is actually a picture from contact tracing. So this gentleman on the right here, I'm sorry, on your right, his name is KP. He's another CDC personnel. So contact tracing, which I'm sure a lot of you are familiar with, but the way it works is, if a person is identified as a contact by that definition I gave you, and then there's a team that will follow that contact for up to 21 days. And they follow them for any symptoms, obviously, mainly fever, but obviously anything. If that contact would come and be found to have symptoms, something called an alert would be called. And so what that would mean is that, a lot of the people that are contact tracers that are in the field, they're not medical. So their job is just to ask a list of questions. If somebody would come up being symptomatic, they would call an alert, and then a team would arrive in an ambulance, which ambulance is basically a pickup truck with kind of like a jaggedy thing over the top of it. And that group would be a hygienist, a medical person, anthropologist, or a mental health person to kind of help with family, and then also just the driver. And so that team would basically come out to try to figure out, is this alert really an alert? Is this really a suspect case? And if it was decided that it was a suspect case, then they would bring that person by ambulance back to one of the Ebola treatment units. And that was obviously in order to try to prevent spread through public transportation or the family themselves carrying someone in. And so, so you can see here, lots of curious bystanders in the back. But that's the other thing, is we tried to be as transparent as possible, just to be open with these populations, to let them know, look, we're coming here. This is exactly what we're writing. This is exactly what we're doing. And the same thing in the Ebola treatment units. I know with MSF, when someone would pass away, a lot of times the family, obviously they're not allowed inside the high-risk zone, but there would be a fence that they could walk up to. And they would bring the body over to the family so at least they could see that body, and then they'd watch the person, put them into a body bag, and walk them to the morgue. And that was really important for families because they really, again, had a lot of fear of what was happening to these deceased loved ones after they died. This is a picture, actually, in the background, you probably can't see, of right up on that river picture I showed you from between Guinea and Sierra Leone. So they decided to set up a little health post because there were so many people actually coming back and forth between that area with kind of a screening area and everything. So I got to give a training just about kind of what a case is and, basics on infection control and some things like that. But so going and teaching about infection control was another part of my experience, which I actually really enjoyed. Another part that we did, so one of the hardest days that I had there was when we had the 45 cases had come to the MSF facility. 2 of the people actually working at this MSF facility in Gekadu were people I had just worked with 3 months before in Central African Republic. So you can imagine, they came to me begging me to help because they did not have enough staff. And I said, I'm so sorry, it's impossible for me to do patient care right now. What else can I do for you? And they said, we need infection control help. We have one local nurse, but we have no one else to kind of go out to these non-Ebola treatment units, the local hospitals, the local healthcare centers, and explain what is a case, how do you treat it, where do you send them, and these types of things. So I actually went to the local hospital in Vicenta with this local nurse and started walking around. And, very careful, but still. So we walked up, and I walked into one of the wards, and this man was saying, oh, while you're here, doctor, I'd like to show you some cases, and I can't figure it out. And I walked up, I said, oh, well, what's this gentleman? And he said, oh, he's a malaria case. And this man was very sick, had a bloody nose, and if you just asked a few of the questions, he definitely was a case. And he was in a room with 5 other people. And that was in August. And so I said, oh, okay, actually, he's a case. We need to call an alert and go from there. But, it was just, these were such intelligent healthcare workers, but they just didn't know really what definitions were because people were stretched so thin that even at the actual ETU, there wasn't a lot of time to go do these outreach infection control methods. And that was a huge learning point for us. So now the CDC actually has made that one of their priorities as infection control education in the non-ETU setting. So lots of my classmates, probably about 50 classmates of mine, have been deployed in the last month to go ahead and do that. This picture, so this was one of the pictures that I took on one of the last days I was there. I don't know if you can see, literally I took it out of a window, that's why it's like a horrible quality here. But this is a picture of a mother, and she's actually dancing, because this is her daughter sitting right here, and she's getting discharged that day. And so she was so excited that she was dancing and couldn't wait to take her daughter home. But it was nice. That was one of the positive and happy things that we saw, because that Ebola treatment unit actually did have a good amount of survivors. And I think, in here and even in West Africa, people forget that there are survivors. I know MSF recently published an article that said they were celebrating their 1,000th survivor. And so, there is hope with this epidemic, but I think that's another thing important to remember. But, okay, I'm done. I was going to say, I know with questions, I think we're going to do a group question answer.
So, any questions now?
But so I was going to play Oprah and do questions, but
okay,
the first thing I wanted to thank everyone for coming, and I wanted to thank Rupa personally for helping us to have a reality check, because West Africa is where it is. Thank you.
And as everyone's here, just so you know, she's been back for more than 21 days. Okay?
And the second thing for the questions before we bring the panel is that Rupa works for the CDC, but does not represent the CDC, and so she can provide information about her experience and answer questions. But if you'd raise your hand, and I'll kind of bring a microphone so that everyone can hear it.
Thanks so much, Rupa. Is there evidence, sort of CDC-level evidence, that removing a person from the home and taking them to an Ebola treatment unit decreases the number of people in that home that are going to subsequently get sick? Because, timing-wise, have they already been exposed and they're either going to get sick or not?
Sure. So from this outbreak, we don't have a lot of great data, but I think from the Kikwe outbreak from Zaire, we do have some evidence that they actually did show really what happened to rates of transmission when people were separated from the family and they were taken out of that home. So, yeah, a lot of this is based on previous outbreaks.
Questions on this side? I'll come into the back. So even though I'm Oprah, I'm not going to give anyone a car. Hey, Rupa.
Hey, Christy.
I just wanted to know, do you have data on mortality rates being different in the pediatric population versus the adult population? Has that come out yet, that their kids are more at risk or less at risk if they contract it?
Sure. So the one slide that I showed you from that New England Journal Medicine article from September, so the infection rates that we found were about 14%, and the mortality rates we found from that were about 75% in children. But it was the same case fatality or mortality rates in the general population. Again, that was from a small cohort of patients, about 1,400 or so. So we kind of take that as you would. I think anecdotally, I would say that that's pretty accurate. But again, that's just kind of what we've seen.
Hey, Rupa, that was great.
Hey, thanks.
Can you, going back to sort of the beginning, can you go through the process a little bit of the tracing back to that original child? Like, how did that go down?
Sure. So this is kind of through talking to some of my colleagues that were on the ground at that time. So a lot of it was very, very rigorous process, as you could imagine. But, it would start with tracing back from cases and then their contacts. And then the nice thing is a system we actually had in place, which is this, this Epi-info system, which is a database. And so a lot of times it would almost make a natural transmission chain if you put in a source infection. So a lot of people, again, I know people from the CDC, from MSF, that were actually on the ground back in March, were really going out looking both at some of the software, but then mainly going into these communities and talking to the villagers. And a lot of these, in a small village, the village chief knows everything that's occurred there most of the time. And so I think that's actually what proved to be the most successful. They would go and they traced it back to these certain regions, but as you can imagine with that first family, they all passed away. So that's how they didn't know really what happened. Was this girl playing with a bat? What happened? They weren't sure, but I think they just kind of traced it back to that village, and then they talked to some of the village elders and other people in that community. The other thing that was a little strange about that first case, a lot of the other past outbreaks start with an adult, because most of the time you can trace it to preparation, or again, like usually it's preparing some of this bushmeat, and it's a woman that's been preparing some type of wild animal bushmeat. And so it was a little bit strange with this epidemic that it actually started with a 2-year-old child. But again, I believe it was from some local people.
So hang on one second, I'll come back here.
Did you want to comment about the effectiveness of ZMapp or Electro?
So effectiveness, I think the hard part is ZMapp has been given, and I think out of the patients it's been given to, it has been proven to be what we consider quote unquote successful. But the other difficult part is a lot of the patients that it's been given to have been in a center or a facility that may have been able to handle that disease already, and they're already receiving a lot more treatment than they probably would have. I think so. I feel like the hard thing and the easy thing to say is that we don't have a lot of data on if it is efficacious. But I would say that the other hard part is that there isn't currently any ZMapp that's distributed right now. So to try to do these studies, I think it's still unclear. But again, I think with that cohort that was given, it proved to be successful. But again, it's hard to know if it was because they were already in a higher level facility.
Rupa, you're talking about specific therapies, but I think we've heard that just non-specific supportive care, the standard that we could deliver here, and apparently have done in the United States with individuals with Ebola, can be very, very successful,
right,
preventing them from getting dehydrated, right, and correcting their electrolyte balance. What's your sense of the value of that versus the need for specific therapies?
Sure. So, I'd say in an area like, obviously in these developed countries, like you said, I think trying to treat basic problems as far as dehydration and metabolic derangements are the number one thing that they've been trying to focus on. A lot of these cases that we know of from past data have been, lots of deaths have occurred, not a result of hemorrhage or this or that, but a lot of metabolic derangements. People lose liters and liters of fluid from their body from diarrhea. In the field, you can imagine there's no way to check electrolytes, so a lot of people would die ultimately from dehydration and from electrolyte imbalance. But actually in the United States and in other developing countries, that's something that's not as difficult to manage here. But I think for as far as treatments go, it's more important for the developing countries to have a treatment like that they'd be able to administer, because they don't have a way to check electrolytes or, do an ART gas or do IV fluids on 300 patients. So I think for that subsect of patients, it's just as important, if not more important, to try to come up with therapies or vaccines.
This is something I saw mentioned in another talk, and it wasn't the only place I've heard it, but the idea of using some of these Ebola survivors to help address the epidemic as healthcare workers, as other workers, also giving them something to do. Did you see any of that on the ground?
Yeah. Actually, there was a guy that was really famous in our area. His name was Saw Bass, and he was on CNN and a lot of other places, and he was a survivor. And he was so proud to be a survivor, and he really wanted to be part of the response. The interesting thing is MSF tried to approach him to see if he'd be willing to go inside the Ebola treatment unit and kind of help with certain things, like with children that would be in there that were unattended, and he was completely against it. He said he felt like he could get reinfected. And no matter, what we explained, he was really against that. But he was still on the part to say, I'll go out and do outreach, I'll go talk to health promotions, I'll explain to people what I can do. And I know in Liberia recently, they're actually trying to use survivors to try to help with this orphan problem.
Do they know they're protected?
They do know. Well, we try to explain to them that they're protected, but I think... Do we know? So I think what we do is, we basically will look at what their antibodies are, the levels in their body, if we're able to send serology in certain places. And then I think, again, but you're right, there's not a lot of good data of that, but usually we'll look to make sure by PCR that they don't have active infection going on, and also that they have a surmounted IgG response.
So let me have another question. So Rupa, I'll ask a question as I'm walking up. So what about our help, what can we do for MSF? And in Denver, Colorado, what can we do for the epidemic in West Africa? And so this is non-CDC. This is Rupa saying, here's how you could help as a community.
Sure. Okay, yes, so this is me. So I think the number one thing is to be public health advocates in the right way. So I am a complete believer in the abundance of caution, and this is a quote from a Harvard friend of mine that I appreciate. She's like, I believe in an abundance of caution, but I don't believe in the abundance of idiocy. And I think public health panic has really occurred, and I feel like people just learning really, really what the correct messages are and what the proper transmission routes are and really the facts, and spreading the correct facts and trying to decrease this panic is probably the best thing that can be done. Because as you can imagine, this domestic situation that we're dealing with, which is completely, I think, we are appropriate to be, worried and cautious, but I feel like it's detracting. It's taking away so much attention from West Africa, and even, a lot of resources at the CDC to deal with when those could be used in West Africa. So I think you guys being advocates for the right messages is probably the number one thing you could do. If you're interested about going over or doing anything as far as a healthcare worker, I can actually tell you about that Aniston course after if you're interested.
You answered one of the questions that I had. Somebody I spoke to said we don't have a healthcare crisis, we have a health communication crisis. So one of the issues that I was wondering about is, now that you've been back, A, are you going to return? And B, are you going to go ahead and be helpful in going ahead and giving straight facts and information to the population who is in a semi-panic mode all over the country?
Yes. So I would say yes to both. I've actually been asked to already go back to Guinea, which I've put off for right now because I have to do a couple things with my division that I just joined. But I think I'll be going to Mali in January to do actually a WASH project, and then also probably some surveillance about what's going on there with Ebola. A lot of my classmates, they told us we're going to be deployed at least 3 to 4 times this year, most likely, because of the way things are going. And then, absolutely, for me, if there's any opportunity that I have to come and speak, even though public speaking is something I fear, but I feel like if it's an opportunity to go out there and get the right message out, I am more than willing to do it. And I was happy to come here and talk to you guys. So
good. Well, let's transition because Rupa is going to be on the panel that we have, and I'd like to invite Kelly Johnson, who's our Chief Nursing Officer. We can probably put the lights up, please. Kelly Johnson, who's our Chief Nursing Officer. Mike DiStefano, who's our Medical Director in the ED, and Sam Dominguez, who's from Peds ID and our microbial epidemiologist. And Rupa to sit at, and I will continue to be Oprah.
And as everyone's getting up here, just for all the residents out there, Rupa, if you want to give a quick 1-2 minutes on how you got to where you are, in case people are like, this is really cool, I want to do what Rupa's doing.
So oops, I turned it off. Can you hear me again? Okay, so it was actually kind of an interesting start. So as you guys know, I did my residency here. I was here from 2005 to 2008 as a pediatric resident. I actually started a cardiology fellowship here in 2009, which was an incredible experience, and I worked with amazing people that were here at Children's. It just wasn't the right fit for me. And I had an incredible mentor who was Dr. Shelley Miyamoto, who actually sat with me and was wonderful and helped me figure out that I needed to take a leave of absence. during that time. And it was actually during that leave of absence that I went to Haiti after the earthquake with a small NGO. And then from there is kind of when it ignited this, like, I have to do international medicine. And then from there I went and went on to do Doctors Without Borders for about 4 years. And then I started with the CDC just in July. But, yeah, okay.
So, all right. So I'd like to start with, we've heard an incredible story about where Ebola really is. And I've seen a wonderful picture of the continent of Africa and the United States put into a small little area of Africa for landmass. Here's the Africa and there's the United States, and that's how it fits in with it, and that's really where the epidemic is. But I'd like to transition to talk about domestic issues more so, and actually ask Kelly Johnson to really start out to give a perspective of thinking about children and thinking about Children's Hospital Colorado as a system. And is this one not working? Is it on? I think it's on. It should be on.
Hi. So what I think my perception of how we've been planning is we had low-level planning until the whole situation in Dallas happened. And we conducted several tabletop exercises to kind of look at where our preparations were and where our gaps were around the planning for preparing in the event we got an Ebola patient or it intensified in the United States. And then when the healthcare worker was infected, it heated, no pun intended, heated up. And we really kicked into planning then. One of the things that was concerning to me was the level of risk that the nurses have and the types of communications that were coming out from our professional organizations, confusing, I think, and escalating the kind of fear and hype around what we needed to do to be prepared and be planned and stay safe. So as a team, we really rallied quickly and got a group of us together from clinical teams, EPI, administration, facilities, every key stakeholder, and met on a daily basis. We actually opened a modified command center. And we have really developed some guiding principles that have evolved over the course of the several weeks that we've been working on this. First and foremost, it's to keep our staff safe. We want to ensure the staff that whatever we end up facing with Ebola, that they're safe. Secondly, is really to treat patients and families with dignity, respect, and compassion. Because I think there is a tendency to maybe not do that as well as we usually do or could do because of the fear around that and our own sort of self-protective mode that we go into. And then thirdly is to create mechanisms that are rational and sustainable. This is going to be here. We're going to be in this for the long term, and quite frankly, a lot of the preparations we've done in the last couple of years and probably going forward will be around infectious diseases, high-risk infectious diseases. So how are we going to be prepared for the next one and the next one and the next one? This level of response will not be sustainable on an ongoing basis. So we really looked at, number one, detection. So what are we going to do to really screen and find these patients so that we know where our risk points are? And that's not quite as easy as it sounds, but I think we're in a really solid place now, rolling out training for all of the entry points throughout our system, and making sure that our frontline people that will be in contact with patients and families and visitors are really scripted and trained to manage the screening process. So we're rolling that out now and becoming more skilled at the screening process. And then the teams up here have been very closely working with CDPHE and the CDC and all of the higher level types of folks so that we keep up on what it is we're supposed to be screening for, how to do it, what the recommendations are across the country. And then various of us are also keeping in contact with our professional counterparts in other children's hospitals and also with particularly University and Denver Health around their experiences, what kinds of things can we learn from their experiences. So, for example, I've been in contact with the CNO at Dallas Children's because they had a suspected case. How did you handle that? How did it go? So it's great to talk to people back and forth and make tweaks if we need to. And then really looking at protection. So all of the PPE that we've put into place, evolving our processes and policies and practices with what comes out of the CDC. But we think we're in a really good place right now, and that training is definitively happening in the ED. The ED's probably better prepared than anyone because they do a lot of, what's the word I'm looking for? Decontamination training. And we have some expert trainers that have been really working on how to roll out that training. And identifying a core team where we can identify a core team, for example, in the PICU, to care for these patients so that we do the right level of training with the right people that will be involved with a case in case we do get one. And how we'll handle suspected cases and confirmed cases and those types of things. And then, absolutely the response, what we have to do from a facilities standpoint to be able to execute on all of the isolation and decontamination procedures we'd need if we get a patient. And then communication. We have tried to not have a level of communication that promotes sort of the fear and anxiety around it, but an informative communication so the staff know that we're planning and prepping and feel prepared to take care of a patient in the event that we face one. So that's kind of the level of planning that we're doing. Did I forget anything?
No, I think, the sustainability, making sure this can be hardwired within the system, in particular with travel questions, and then keeping everyone safe, families getting the best possible care. And it's a continual state of readiness, and it has an iterative process where we're continually trying to improve things and improve our processes. And so that's kind of the key component. So I'd open it up to questions from the audience for Rupa or the other panelists about anything that you've been interested or have questions. And in fact, if you've heard things that are rumors, it would be a good time to bring those out so that we hear about what the questions are. And as Rupa said, dispel the myths.
Thanks, Christy. I had heard, at least from the adult folks over at the university, that no trainees would be participating in any of the care. I just wanted to see if that was a system-wide and applicable here at Children's as well.
Yeah, go ahead, Sam.
So that has come from on high that no residents or fellows or students will be allowed to care for anyone with a confirmed case of Ebola. There are some people that feel strongly that should not be the case, and in particular for fellows. So I think everyone is on board for students and residents, but the question that some people are debating is whether fellows should be involved. Currently, they are not allowed to touch patients who have a highly infectious pathogen, but they would be allowed to be involved in discussion of their care and round on them and those sort of things. That may change in the future, but currently that's what the stance is.
So I heard a Carol Rumack sighting. Oh, you're in the front. Do you want to make any comments from the GME perspective? Carol? Or are you fine? I mean, if you think about the principle of a workforce that is well-trained, experienced, and feasible. So those are the other kind of things that are important. But I see people here.
This came from the infectious disease experts. We put it out from the GME office because that was a decision made all the way through the UCH health system. So it's not that we made that decision. And my theory was that a fellow ought to want to do that, but that is not the decision that was made. And I think the risk factor is what they're really worried about. ACGME just came out with a requirement this past week that says every resident fellow needs to be trained in how to don and take off the protective equipment. So there is a video. If you didn't notice it flying through the many emails that came along, look back through those because there is an email with a video that shows you how to do that.
We also go ahead. Go ahead.
We have the luxury in terms of thinking about one Ebola patient, but if we have pandemic flu and we have 100 patients we need to care of, then that's a very different story, and a very different case scenario where residents, fellows, everyone in this hospital will be taking care of those patients. So I think it depends on how many patients we have and what the situation is as well.
And we had a tabletop discussion. Phil Niemer and I ran a tabletop discussion on Monday with the house staff, and learning from these experiences is really important. Direct contact may not be as important, but learning from the experience. And then the role of leadership that the medical, house staff actually have is really important to deal with the myths, help with the families, help with the rest of the situation. So, Claudia.
This question is for you, Rupa. I work in the third world, and I had a lot of patients with cholera. And I was using the World Health Organization treatment for cholera. And when this came up, like I told Dr. Ogle, it's funny that these things are not coming out, but if we had a patient that would like to use those protocols, because they have moderate, mild, moderate, and severe disease and oral rehydration, are they thinking about putting that up and saying to people, this is what you have to start training with? Because I don't think people that haven't seen cholera know how much diarrhea that is.
So you mean obviously in Africa, in these developing areas? So, MSF, which again, that's all I can really attest to. WHO as well has a lot of protocols, but MSF has been doing VHF for about 20 years. And I think they use the protocols as far as oral rehydration, that's a similar protocol that they will try to use. I know I talked to some people the other day about if IVs are being used in the field. I think that varies from Ebola treatment unit to Ebola treatment unit, but they do really try to push the actual oral rehydration because obviously even with IVs, there's a huge risk with, obviously sticks and things of that sort. So they try to, but the other thing is the sheer numbers. So some of these ETUs have over 200 plus cases in each, and there's only a very specific amount of staff that will go in. And if someone is too weak to even put that ORS up to their mouth, I was explaining the differences in this case. In the cholera treatment units, family is allowed in there and they're helping. But in this situation, family is not in there with these cases and these patients. So it's up to the patient to do it, or if there's staff that has time. But for 200 people, if the staff goes in, that's maybe 6 staff members, and they have to go in, and they're only allowed to be in there for technically an hour because they're in PPE and it's already very hot, they may need to get 30 blood samples in that time instead of constantly pushing the ORS. So I know that's not really an answer. I think they try the best they can with these protocols, but again, I hate to be realistic. I think in certain places it's really hard to get the amount that people need because it's several liters, as you know.
Yeah, Steve.
I spoke with International Medical Corps, and they said it's costing them about $1 million a month, I think. I was a month. And the single biggest cost is those PPEs are $200 a PPE, and they can only be used for an hour, and then they have to be discarded. And so that's been the real challenge for a lot of these NGOs is the cost of the personal protective equipment. And I don't know, Rupa, if you want to comment on that and the challenges that some of these NGOs have about getting enough money to keep themselves in PPEs.
Sure. I think, again, as you guys are getting familiarized with yourself with this PPE, I know a lot of you have also faced the challenges, not only the PPE that's in the field, but the PPE they can find. So, for example, MSF, the hoods that they wear, that classic picture you see with the people in that, the spacesuit and those hoods that go down to here, those are actually made for them personally by DuPont. They are not manufactured by several people. It's a very specific to made order. And in the past with these outbreaks, it's been fine. But now you can imagine people are trying to order all different types of NGOs appropriately are trying to order PPE. And the challenge is now there's different types of PPE in the field. And the way to doff that and don it is very challenging. So I think the amount, like you said, one of these suits, most of the time, the only thing you can reuse from those are goggles for the most part, and maybe reusable aprons, but everything else that you see in those pictures are thrown away, as again, you've probably seen. And yes, I think the amount of money that people are spending is huge on it, but and also the production of it needs to be ramped up as well.
Jim.
A follow-up on that, Rupa, because I heard you say a couple times that most or many of your EIS colleagues were going to be redeployed and deployed maybe 3 or 4 times this year. That means they're not on the projects that they were intended to be on, correct?
That's true.
And so I think it points out that, I've heard the figure that since 2002 we've cut the CDC and NIH budgets regularly since that time. And so it suggests to me that, and certainly events of the last month or so suggest to me that we really weren't prepared here. And do we have the resources even here to do what we need to do, both for what's going on in this country as well as elsewhere?
I think that we do have the resources. I'd say, I know recently the military has become involved. And I think for us, logistics, as I explained, was just as much of the problem as the actual supply problem. And with someone like the U.S. military who's able to bring in supplies and logistically both set up these Ebola treatment units and bring in the bring in the PPE and get the things to where we need to be, I think that's a huge thing that we're one of the few countries that has that capability to bring to West Africa. So I think that we do have the capability to do it. The hard thing is even once we get those Ebola treatment units set up over there now, and even if we have the right PPE, the matter is to fill them with healthcare workers. Because as you can imagine, as I told you, over 400 healthcare workers have been reported to be infected. I think the number is much higher, and over 200 have died. So not only is it the logistics and the supply and the money problem, but it's also really the human resources, which, as you can imagine, people over there and any other international expats that want to go and volunteer, that's a huge challenge, I think, with the numbers in these ETUs.
What are the prospects for developing a vaccine? I know CSU got $2 million, which seems like a drop in the bucket, but how realistic is that?
So I know I'll speak to, there's 2 trials actually that are currently ongoing. So there's the vesicular stomatitis virus vaccine and also a chimpanzee adenovirus vaccine. They're both, similar in the aspects that they are kind of animal-based viruses. Correct me if I'm wrong. And they are, they take in a small part of an Ebola gene into it, but that's obviously not able to replicate. And the thought is, they'll be injected into a human who is thought to not have any immunity, obviously, against these animal viruses, and then be able to work from that point. There's a lot of great data on animals, on non-human primates, that show that these could be very effective. But there are phase 1 trials actually going on right now at NIH, for, I think, the VSV virus vaccine, and also for the chimp adenovirus. Just this week, the Swiss regulatory agency just approved for WHO to start trials in Lausanne. And also they're going to, I think, start to do some trials in Mali, the Gambia, the UK, and some other things with at least these 2 vaccines. And I know there's other ones that are in the process of being developed with other things like adenovirus and other animal viruses.
So as a resident, we've heard about the screening questions, but we haven't heard much else about protocol and things like that. But can you walk us through, let's say there's a patient who comes in who's traveled from one of these hot areas, what's going to happen?
Do you guys want to do that, or you want me to?
Yeah, I can speak to it. So as a resident, that should not be your primary focus, because hopefully if the system works, you won't have to ask those questions. So it's at the point of entrance we're going to ask the questions of, have you traveled and where have you traveled recently? Because we're trying to make this as broad as possible, because prior to Ebola we were talking about MERS, and so there seems like every 6 months Sam and I are talking about the most recent potential
We have job security
outbreak, and so what we want to do and what we've set up is to make sure that this is going to be applicable to other highly infectious organisms. So it's at the point of entrance. So at the Anschutz campus, it's right as they walk through the front door, the questions will be asked to the patients. Once they're identified as potential, as a potential case, whether it's MERS or Ebola, we then walk them straight back to a room. And at that time, in what we are suspecting with Ebola, when we get to them, they're probably going to be fairly stable. And we'll place them in a room, limited contact, and then we call the epi folks when they come in. Prior to that, we're going to obviously need to don our PPEs, but realistically, it's limiting the contact that the patient is going to come into with our staff until we get a yay or a nay from the epi folks of saying this is a suspected case or this is not a suspected case. Because what we don't want to do is have a lot of people going in and out of the room. So the very beginning of our process is really about limiting contact to the patient and the family. And what we've learned is that sometimes the families walk off and not realizing we got to get the family in the same room with the patient and making sure that we can contain them as best. And that's the front end of our process is probably is
best spoken to by limiting the contact and making sure that we get the epi folks in.
The other thing I would add is that, the state health department, just as they're supposed to be doing, is monitoring people for 21 days who've traveled from West Africa. And they have a very robust system. They have numbers of people they're doing. They're not going to tell us how many people, but they're doing a good job doing that. And so we have a good idea we might know about somebody.
So I just want to add one more thing. We are doing screening throughout the whole entire network. So if we identify in a network, it's the same principle to isolate, call epi, and then we will transfer any case up to this campus, the Anschutz campus. We will not be doing the extended diagnosis or treatment out in the network, including our inpatient units at Memorial.
And Chris's point should be, emphasize the fact that now every single person that enters this country from West Africa is being followed by the CDC. So if they come to Colorado, the health department is being alerted to all those people. And they're being called every single day by the CDPHE to ask if they have symptoms. If they have symptoms, they are told to come, if they're an adult, to the university, or depending where they are, but in the Denver metro area, the university or Denver Health, and if they're a child, they're going to be told to come here. So they will be called to come in very early on in the course of their disease, which is when they're least infectious and best able to be handled. So from that standpoint, that point should be emphasized.
So this may be overly aggressive, but as a healthcare worker that works on a large campus the way that we do, I just wonder if there's any thought to making PPE, just simple PPE, gloves, masks, available at various entrances. There's always a case where a healthcare worker may be on the sidewalk outside the hospital or something, and a kiddo does not make it to the expected entry point, like the ED. And certainly we don't want to leave a family out there and not address their needs. So I'm just wondering if there's any thought about putting some PPE stations, cafeteria, other entry points, et cetera.
Yes, so they're working on that, actually. So at every point of entry, there should be now PPE kits for every network of care site, every point of entry into our system. There have been dispersed PPE kits for people to evaluate patients in case that happens.
So I think my question's more of a virology type question. So you'd mentioned that we see this sort of time course of IgM and IgG, and you mentioned that we don't really know what the protective titers are. For viruses generally, or for this virus, do we know that it's more of an antibody B-cell type, response that provides protection, or is it more of a T-cell, cell-mediated sort of response? Because I know there was talk, at least, or I heard a couple months ago about sort of pheresing some of these patients and doing intravenous immunoglobulin therapy, but is that actually proper in this case with this viral infection?
Yeah, sure. I can talk about the convalescent serum part, and then I'll hand the other part to Sam. He probably can answer that a little bit better than me. So as far as the convalescent serum, we don't have a lot of efficacious data. I think back in Kikwit as well, there was, 7 out of 9 people that were given convalescent serum were proved to have survived after Ebola. But again, the hard part was they were never really able to test the efficacy of that because they thought maybe a cohort of people that would have survived regardless. The other hard part about the convalescent serum in West Africa are, bloodborne pathogens like hepatitis, HIV, syphilis, all of these things. And a lot of those places do not have screening for it. So I think it is something that could be utilized because it's widely available if these, survivors are willing to give that and blood could be matched. But the hard part is, truthfully, we don't have data to say if it's efficacious or not, and there could be risks associated. But as far as the pathophys, I'm going to pass that over to Sam.
Yeah, and I'm not sure I can answer your question either. I think that, as Rupa was saying, it's not known for sure. We don't have data about if you have an IgG response, can you get reinfected? I think the thought is that you can't, but that hasn't been definitively proven as far as I know. So the thought is that if you have Ebola and you recover, that you are immune. I think people think it's probably lifetime immunity, but no one knows that for sure.
Hi, I have a quick question. So we all work in a pediatric setting, which I think adds an extra layer of complications to this. So I guess it's a twofold question. One for Rupa. Were you very successful in isolating those pediatric patients from their families? And my second question is, do we have a plan in place? Should we have a pediatric patient present here, what's our plan in terms of supporting that family. I couldn't imagine being separated from my child if they were sick and suffering.
So I'd say in Guinea, I don't want to say luckily because it's not luckily, but a lot of the children that came in that were younger, most of the time the parent that was there with them also were a suspect at the time. So majority of the time we would keep them together. But I would say that in Sierra Leone, for example, so Emily Veltis, that picture of that woman I showed you who was with the survivor, some of the stories there were just heart-wrenching because what they would try to do is if there would be a child who would have been a suspect but tested negative, but then maybe the parents had tested positive, so the child would be sent home and the parents would be in an Ebola treatment unit. And then what happened is that, no one in the village where this child was would want to keep the child. So the next day they'd find this child staying with their parents in the confirmed area. So I'd say that, no, it wasn't always successful. And the other thing is what are you going to do? When they go, of course, there's no one in a village that wants to maybe take this child. They want to be with their parents. Their interaction had already been so much. So I'd say it had been plus or minus. And the other thing in Guinea, I know what we were doing is there was a lot of other mothers that were admitted in these units. And so sometimes if there were children that were unaccompanied, the mothers would go and try to take care of, if they were strong enough to, some of the other unaccompanied children. But that for sure was an ongoing struggle.
So I can say that question we've are trying to deal with. It's a very difficult question to answer. So we have a working group that's thinking about inpatient care issues. And we've also been talking to colleagues around the country about what they're thinking about how they would handle that situation as well. It is a very difficult situation on several points in terms of, A, what's the ethics of that in terms of separating a child from their parent, but B, it's also a public health issue. So if the parent is in the room, are they allowed to leave the room because then they become a suspect patient as well? And then would you let the family use PPE because we all know that having a family use PPE, having to take it off is the hugest risk, and they're not trained to do that. And there's been stories about how that just is a complete disaster. And so that's another part of the equation that needs to be taken into consideration. I think how we're thinking of is two different situations. One is the vast majority of patients that we would get here would be the suspect patient, the rule in, rule out Ebola patient. So I think if we get patients, 90% of the time it's going to be those patients, and they're going to not be that ill to begin with. And so while we're still working them up, what we tentatively are thinking about right now, this is still a work in progress, is that we would let one family member into the room. The ICU has expressed a great concern that having no one there is actually more difficult because the parent can actually soothe the child, can help with the care of the child, because they're going to be all walking in the room in spacesuits, and they're going to be scared as it is, and then you're going to spacesuit people walking in the room too, and how is the child going to react to that as well? And so that's part of the equation too. So we're talking about Skyping. We have Skyping availability for the patient. The family can talk to them from outside the room, and so that will be put in place as well. But I think until we've ruled in a case of Ebola, the one parent will probably be allowed into the room, depending if they're healthy or not. But then that person also becomes a suspect patient. The health parent will be very involved with that as well. And if we have a confirmed case, then things sort of change, and we haven't fully decided how we're going to handle that yet, but we're still thinking about those issues.
So, moderator's prerogative, it's 1:30. I want to give great gratitude to Rupa for coming, and thank you for sharing. And thank you, everyone, for coming and participating in the conversation. This is an ongoing, situation of how do we continue to prepare and be safe, and thanks again.